Yes, sir.
Yeah, thank you. And I'm going to speak on an update on a recent technique which we have been doing in our practices. And this is on laser cyclophotocoagulation using the micropulse laser. Intractable glaucomas in the past have been difficult to handle, and the glaucoma and aphakia, trauma, neovascularization, penetrating keratoplasty, post PK, and eyes with poor vision and painful blindness. All of these procedures we were doing in this intractable, hard to treat glaucomas. We were doing cryotherapy in the past, we were doing diathermy in the past, and then we moved on to the diode laser, the continuous wave diode laser. For quite some time, we've been using the diode laser. And now, as a recent addition to our armamentarium, we have the micropulse diode laser. This is the older one called the G probe. I think you're all familiar with the G probe. It used to be placed with the side view, or the probe is visible there in the picture. It's called the G probe. It used to be placed in multiple spots in a circumferential manner around the eye. And the complications with the continuous diode laser used to be conjunctival burns and iridocyclitis, postoperative pain, hyphema, vitreous hemorrhage, hypotony, choroidals. And we used to have quite a few complications, and very rarely even a sympathetic ophthalmia has been reported. The new micropulse actually has made life easier for all of us. And this uses micropulse technology to denature tissue while minimizing collateral damage, and applies a series of short repetitive bursts of energy and a sweeping movement, unlike a spot movement. The probe shape and contour is different. The movement is a sweeping movement, unlike the single application of the spots. The duty cycle is 31.3% with an on time of 0.5 milliseconds, off of 1.1, and it is applied in each hemisphere for 80 seconds with an energy of 2000 milliwatts. And I usually do it in the operation theater setting because we are administering a peribulbar or retrobulbar block. So these are the machine console settings of 80 seconds and 2000. And some case examples of where I have done this: advanced primary angle closure glaucoma, and the patient was refusing surgery. And we dread the complications of advanced angle closure glaucomas, in which you dread shallow ACs and other complications. This patient agreed to undergo this procedure and has done extremely well after the micropulse cyclophotocoagulation. This is a patient with good vision. Similarly, a patient with very poor compliance and intolerant to all medications which you can think of, prostaglandins, brinzolamide, and even the other drugs which you brimonidine. So therefore, the patient was offered the laser photocoagulation and the cyclophotocoagulation. She has also done extremely well after this, and now she applies only one medication. You can note the periocular pigmentation and the hyperemia in the eye. This is yet another patient with advanced glaucoma, had a phacotrab first, didn't we wasn't enough. Then we added a tube that also didn't control the pressure. Patient has started to have raised pressure and deteriorating loss, and therefore we decided to do about 180 to 200 degrees of this particular micropulse CPC, and finally settled on the pressure is now under control with one medication. So another patient who had a Boston K-Pro in both eyes, and this patient also seemed to be deteriorating because we could not measure the intraocular pressure adequately. The disc seemed to be getting progressively cupped. So we decided to do the micropulse CPC in this patient as well. We did one eye first and then the other eye, and then patient seemed to stabilize and hold on. The pressure seemed to get control with the micropulse. The continuous wave is definitely destructive, and these are pictures from Paul Chew's publications, in which the obvious damage and characteristic destruction or cyclodestruction is seen, tissue retraction and shrinkage, whereas the micropulse does not show any evidence of clinically detectable tissue damage and seems to be a much better alternative. There are a few problems with cost and logistics in the Indian scenario. We do get a few iridocyclitis. Some patients experience a vision loss of one or two lines. The pupil sometimes remains dilated, and but serious complications like choroidals and hypotony I have not seen. We do have an Indian publication in which we have found one hypotony in the last 2.5 years in about 80 odd eyes. So we are generally try to avoid treating thin areas, blood clots, and recent post-ops and inflammation. We should not do this procedure. Many publications in the recent journals, the Academy's Journal, the Journal of Glaucoma, and many other journals. And data shows that the IOP lowering is quite good, and you probably get about 25 to 35% IOP reduction, and definite reduction in the number of medications needed. This is our own experience, which has been published in Springer's International Ophthalmology recently, an initial Indian experience of about 55 eyes, and very encouraging results with very few complications, serious complications. It is said to act like pilocarpine in which the drug induces ciliary muscle shortening, a scleral fur rotation, PM movement, and Schlem's canal changes. And therefore, the scleral outflow increases through the extracellular matrix remodeling. So most probably it's said to work somewhat like pilocarpine. So this is a video of how it is done. A sweeping movement. This is with the speculum on, and as you can see, the sweep movement proceeds for about 15 seconds, about 5 sweeps in one hemisphere below and 5 sweeps superiorly as well. And this is in many patients we find people have been using drugs for a long time. The eyelids are tight. You're not able to apply a speculum. So this is one technique which I have learned to do without a speculum. You can actually learn to use the cotton tip applicator, spread the eyelid apart, and then use the probe itself to keep the eyelid away. And this is another method of doing the cyclophotocoagulation. So take home message from my talk today is very brief. So the micropulse cyclophotocoagulation cyclodestruction is an effective and a safe alternative to the continuous wave CPC which we used in the past. Can be used even in early and moderate glaucomas and not just intractable glaucomas. Patients with fair to good vision have been done in our series itself. Definitely reduces the need for medication with fewer complications. Should avoid in eyes with recent surgery and inflammation. But we definitely need longer term studies and follow up to look at the worrying aspect of vision loss and other complications which can happen. Long term studies definitely needed. And we need to wait to see what are the long term outcome of these patients and how many of them need retreatment. How long does the IOP lowering last in these patients? Thank you all. My sincere thanks to the German Ophthalmic Association for having me here and letting me talk on this topic. Thank you very much.